Michelle orders pizza for herself and her friends. At the end of the night, she notices a burning sensation in her chest, something she has experienced before. Michelle decides it's time to talk to her doctor. The doctor tells Michelle that the symptoms she is experiencing are likely heartburn or acid reflux, which are characteristic symptoms of gastroesophageal reflux disease, also known as GERD. GERD is a condition that develops when symptoms or complications result from the reflux of stomach contents into the esophagus, and it affects an estimated 19 million people in the United States alone. GERD is said to appear most often in South Asia and Southeast Europe, and women are 40% more likely to report experiencing symptoms linked to GERD than men. Old age has an inconsistent association with an increased risk for GERD, but it is more strongly associated with complications of GERD. There is a similar prevalence of GERD among different races, although whites are at a greater risk for conditions such as erosive esophagitis, esophageal and or peptic strictures, Barrett's esophagus, and esophageal adenocarcinoma. The doctor tells Michelle that she is going to be prescribed pantoprazole, and he describes it to her as an irreversible proton pump inhibitor most commonly used to treat acid-related disorders such as GERD, esophageal gastric and duodenal ulcers, erosive esophagitis, Helicobacter pylori infections, and Zolliger-Ellison syndrome. Michelle is prescribed 40 milligrams of pantoprazole to be taken orally once daily for 4 weeks in order to reduce the amount of gastric acid secreted in her stomach and lessen the occurrence of heartburn. It is recommended that Michelle report back to her doctor about the recurrence of any symptoms so that her prescription can be adjusted as needed. She is advised that pantoprazole may cause headaches, diarrhea, constipation, flatulence, abdominal pain, nausea, vomiting, and dizziness. Some sporadically reported side effects of pantoprazole have included belching, skin rash, shoulder pain, joint pain, pruritus, and weakness. Some more severe adverse effects have included anaphylaxis, angioedema, anterior ischemic optic neuropathy, pancreatitis, anemia, hypoxia, rhinitis, and contact dermatitis. It is recommended that Michelle take pantoprazole in a fasting state so that absorption through the small intestine is not delayed. What normally happens when you eat food? When food is ingested, acetylcholine is released from the vagus nerve and gastrin is secreted by the pyloric antrum of the stomach. These molecules bind to their respective receptors on the parietal cell, the acetylcholine M3 receptor and the cholecystokinin B receptor, which stimulates the release of histamine from endochromaffin-like cells via cyclic AMP and intracellular calcium. The histamine will bind to its H2 receptors, and all three of these decoupled protein receptors will help activate the hydrogen potassium adenosine triphosphatase. When this ATPase is active, it will undergo phosphorylation and dephosphorylation that will cause conformational changes, allowing for the movement of protons out into the lumen of the stomach and potassium ions into the parietal cell. The protons found in the parietal cells come from the conversion of water and carbon dioxide via the enzyme carbonic anhydrase into carbonic acid and its subsequent breakdown into protons and bicarbonate. The bicarbonate is transported out of the parietal cells in exchange for chloride ions to maintain the charge, and then these ions are transported into the lumen of the stomach. In the lumen, the hydrogen and chloride ions combine to form gastric acid, also known as stomach acid. How does pantoprazole affect this process? When someone takes pantoprazole as an enteric-coated delayed-release tablet, this coating protects the prodrug from the acidic environment of the stomach. Pantoprazole is absorbed in the small intestine and travels through the bloodstream where it enters the gastric parietal cell. It then diffuses to the extracellular canaliculus. For pantoprazole to interact with the hydrogen-potassium ATPases in the parietal cell, it needs to be activated. Activation occurs by the addition of 2 protons to the nitrogens on either side of the sulfur group. Pantoprazole has 2 pKa's, one at pH 3.83 and the other at pH 0.11. The first pKa leads to ionization and accumulation in the acidic region of the parietal cell canaliculi, where acid is secreted with a pH of around 1. The second pKa provides the second protonation of this benzimidazole and causes the rearrangement of the sulfonyl into cationic sulfenic acid with a pharmacologically active drug, a cyclic sulfonamide. This compound opens and covalently binds via covalent disulfide bonds to the sulfhydryl functional groups on cysteines 822 and 813 on the luminal side of the hydrogen potassium ATPase, leading to the irreversible inhibition of the proton pump. Long-term use of pantoprazole has not shown a decrease in its acid inhibitory effects or signs of tolerance. Since the proton pumps are inhibited covalently, restoration of acid production occurs mostly through de novo synthesis of the hydrogen potassium ATPase, and it is assumed that about 75% of the pumps are active when PPIs are biologically available, so most are spared altogether. Kinoshita et al. 2018 suggests that long-term use of pantoprazole and other proton pump inhibitors may, however, decrease the absorption of iron, calcium, and vitamin B12 because the reduction in gastric acid lowers the amount of these nutrients that can be released from food. How is pantoprazole metabolized and excreted by the body? Once it enters the blood, the majority of pantoprazole is bound to the human serum albumin protein, and the prodrug travels through the circulatory system until it reaches the hepatocytes of the liver, where it undergoes metabolism by cytochrome P450 enzymes. Pantoprazole is metabolized into the inactive metabolite 5-hydroxypantoprazole, primarily via the CYP2C19 isozyme by phase 2 metabolism, which includes demethylation and sulfation. Following this is sulfate conjugation and some sulfone or sulfide formation by CYP2C19. CYP34A works as part of phase 1 metabolism by facilitating some sulfone or sulfide formation from the parent drug by oxidation. About 80% of an oral or IV dose is excreted in the urine as pantoprazole metabolites, including pantoprazole sulfate, pantoprazole sulfate sulfone, and pantoprazole sulfate sulfide, with the remainder excreted in the feces via biliary secretion. Pantoprazole has few recorded drug interactions as it does not compete with other drugs metabolized by the same CYP450 enzymes in the liver. For example, clinical trials have recorded that diazepam and pantoprazole do not interact, even though both are metabolized primarily by CYP2C19 and CYP34A. We've discussed what pantoprazole does to the body, but what exactly does the body do to pantoprazole? Clinical trials where pantoprazole was administered to patients with GERD or other related conditions such as non-erosive reflux disease were used to determine its pharmacokinetics. Patients' blood was sampled to determine the following data. Cmax, which is the maximal drug level obtained with the dose, was 5.73 micromole per liter. Tmax, which is the time at which Cmax occurs, was about 2 hours. AUC, the area under the plasma drug concentration time curve, which reflects the actual body exposure to a drug after administration of a dose, was approximately 5 microgram hour per milliliter. Bioavailability, which is the fraction of an administered dose of unchanged drug that reaches a systemic circulation, was 77%. And T-half, which is the mean plasma elimination half-life, was 1.2 hours. Pantoprazole's duration of action is about 24 hours, which is about the time it takes for the body to synthesize new hydrogen-potassium ATPases, and its volume of distribution is approximately 11 to 23.6 liters, meaning that the drug distributes mainly in the blood rather than in the intracellular fluid. What is pantoprazole and where did it come from? ASL, which was a research company within the pharmaceutical company Astra, started the search for a drug that would inhibit gastric acid secretion in the late 1960s. The first attempts failed, but in 1972, gastric fistula dogs were used as test subjects. They soon after adopted a compound called CMN131 from the pharmaceutical company Servier, which contained a thioamide that was toxic to humans. And in 1973, benzimidazole was determined to be a powerful anti-secretory compound that was not toxic. Timoprazole, the sulfoxide metabolite of this non-toxic compound, was discovered and used as a new lead compound. However, long-term use caused enlargement of the thyroid gland, atrophy of the thymus gland, and inhibition of iodine uptake. In response, some literature research was done that identified substituted benzimidazoles as having no effect on iodine uptake, and the addition of these substituents showed no effects on the thyroid or thymus. The class of benzimidazoles was optimized by adding substituents to the pyridine ring of timoprazole in order to obtain a higher pKa, which would maximize their accumulation in the parietal cell of the stomach. Pantoprazole has an additional 5-difluoromethoxy substituent and a 3,4-dimethoxy substituent on the 2-pyridine-2-O-methylsulfonyl group. Pantoprazole's structure includes a benzene ring, 3 ethers, a secondary amine, a sulfoxide, and a pyridine. It is known chemically as 5-difluoromethoxy-2,3,4-dimethoxypyridine-2-O-methylsulfonyl 1H benzimidazole, and it is most commonly prescribed as an enteric-coated delayed-release tablet given as an oral treatment for conditions related to excessive acid secretion in the stomach. However, it can also be administered as an oral suspension and intravenously. It is sold under the brand name Protonix and marketed as a sodium salt by Wyeth Pharmaceuticals Incorporated. In the early 1970s, the proton pump was discovered and PPIs were developed. Wyeth Pharmaceuticals started research in 1977 and after 8 years introduced pantoprazole in April 1985. The first PPI, omeprazole, entered the U.S. market in 1989 to treat acid reflux. By 1994, pantoprazole was in use throughout Europe. but it wasn't until 2000 that pantoprazole was approved by the Food and Drug Administration for the healing of erosive esophagitis using 40 mg daily oral doses for 8 to 16 weeks and for the maintenance of erosive esophagitis using 40 mg daily doses continuously. It was the fourth PPI approved by the FDA for treating erosive esophagitis associated with GERD. The intravenous form of pantoprazole was approved in 2001 for the short-term treatment of GERD patients and those unable to tolerate oral pantoprazole. In 2007, an oral suspension was approved for the treatment of GERD in patients who had a history of erosive esophagitis and could not tolerate the capsule. Pantoprazole can be synthesized by reacting 5-difluoromethoxy-2-mercaptobenzimidazole with 2-chloromethyl 3,4-dimethoxypyridinium hydrochloride and water using sodium hydroxide to make solid pantoprazole sulfide. The sulfide is then oxidized in water using sodium hypochlorite over a period of a few hours, and the reaction is completed by high-performance liquid chromatography. The remaining hypochlorite is deactivated using a 5% sodium metabisulfate solution, and the pH is adjusted to be in the range of 7.5 to 8.0 to yield the sulfoxide structure that is pantoprazole. The sodium salt is formed by taking pantoprazole and reacting it with sodium hydroxide using acetonitrile as a solvent, and it is then given a dichloromethane to remove traces of acetone. Now that Michelle knows about pantoprazole, she feels more confident taking it as prescribed by her doctor.